But something that should be really known about painful sex is that there's a lot of reasons why someone might have uncomfortable or painful penetrative intercourse or sex. And it could be from endometriosis, it could be from pelvic myalgia. And pelvic myalgia is where the muscles are really tight and hypertonic, is what we would call it. It has been called vaginismus historically. The newer term is pelvic myalgia. Other reasons could be because of hormone changes. There could be other kinds of physical anatomical problems that cause pain, and there's more, but I think that's enough of a list. But for vulvodynia specifically as a cause for painful sex.
Painful sex? And you know what? It's something that nobody really talks about. And so we are going to address it. What the heck is it? What can we do about it? And Hullender Rubin is like a doctor of Chinese medicine and acupuncturist. She's like a leading acupuncturist. And I actually have to say you are a pioneer in our field because you've done so much research. And I'm like super honored that you are coming on here to share your wisdom with us. So I think let's get right on it. And, you have a specialty with regards to vulvodynia. Do you want to speak to that? Like, the definition, what it is, all that.
Sure. Thanks, Mary. Thank you so much. Tanya also as well. Thank you for having me. So vulvodynia is essentially a pain in the genitals, especially female genitals, people who menstruate. And it is not explained by any other pathology. And it is a chronic pain, and it can come and go. It can be provoked. It can be generalized, meaning you have it all the time. It doesn't matter where it is. It can be provoked in the sense of like only it happens when you have some type of contact or pressure or rubbing, some kind of thing like that. The other thing about it is that it can be intermittent, where it can come and go, like when it is provoked, or it can always be there. It will never go away. But something that should be really known about painful sex is that there's a lot of reasons why someone might have uncomfortable or painful penetrative intercourse or sex. And it could be from endometriosis, it could be from pelvic myalgia. And pelvic myalgia is where the muscles are really tight and hypertonic, is what we would call it. It has been called vaginismus historically. The newer term is pelvic myalgia. Other reasons could be because of hormone changes. There could be other kinds of physical anatomical problems that cause pain. And there's more, but I think that's enough of a list. But for vulvodynia specifically as a cause for painful sex, it is something that is really hard to get a diagnosis for, because you have to rule out all that other stuff first. And the treatment isn't really clear, and it's often multimodal. So you have to do lots of different things like medications, physical therapy. I would recommend acupuncture. As part of my research, we found that acupuncture did provide benefit for women, reducing their pain by about 50%, and it stayed reduced when we followed up with them 3 months after the end of treatment. So vulvodynia is and just painful sex in general can be something acupuncture can address, but I also like to do it in a team to support a patient, because it's about the pain, it's about the skin, it's about the muscles, it's about sexual confidence, it's all of the things.
So thank you so much for addressing the acupuncture piece. I mean, that you have to actually go to a practitioner to do this. So just to provide a bit more guidance, how would one do this? Meaning, like, how long would it take? How long is the treatment therapy? Is it once a week? Is it once a day? Let's give us the goods.
Oh, Mary, I love your question. So in the research, how we designed it, because this is something that you don't want to just try and treat every couple of weeks. The first part of our study we set it up where people got 2 treatments a week for 6 weeks. And then we followed up for 6 more weeks with 1 treatment a week. So we kind of really went after the pain for the first 6 weeks. And then we tried to ensure that we maintained the reduction in pain for the following 6 weeks. And so when I see someone, when I start to work with them, when you're in a research study, you have to reduce all of the other influential factors. I don't have to do that in real practice. office, I can do all of the things, right? Like we can do the
Mhm.
PT, we can do the acupuncture. So I will have them come twice a week for the first 6 weeks if they can afford to do that, or their insurance will cover it. Sometimes, you'll have limitations, but if they can't, I'll see them once a week, and then I'll add in other kinds of therapies to address pain at home.
So does that include, I mean, we're going to go ahead. And so this is like a precursor to another episode with
Yeah.
regards to the TEAS machine. Do you
Yes.
say that? Okay, awesome. So you guys need to watch out for that podcast because we're going to go into details around that. But let's continue. So here's the thing. I can just imagine people at home thinking, acupuncture once or twice a week. Are you going to do it on my vajayjay?
No, great. Also, really important. I get that question like the first time. Is like, where are you going to put the needles? In fact, in our in our research packet, we clearly said no needles will go in the genitals at all. So while there is an acupuncture point near the genitals, but not in the genitals, we didn't even use that one, even though it is indicated for pain because it's so invasive, and we wanted people to want to actually try the acupuncture. And honestly, we know there's lots of you and I, Mary, know that there's lots of ways to use acupuncture. There are many ways to the park, as they say. So what we do is we try to use points that are traditionally selected to address pain, but also in the research, actually, we looked at Chinese medicine diagnosis. So we did an assessment, we did a pattern differentiation, and then we designed a treatment around that. So we individualized treatments to what the person was experiencing. So some people with vulvar pain, that's because of vulvodynia, it'll be worse when it's really cold out, when it's like maybe if they've been swimming and they're wearing a swimsuit and then they notice that the pain gets really worse after like walking around in a wet swimsuit. There's other folks that really notice that, oh my gosh, if I have a hot bath, it is worse after I do that. Or if I get really hot and sweaty, it is terrible. So those temperature differentials are important in our diagnosis. And sometimes people don't notice anything. Maybe it's like there is no difference in the temperature. And it's just that the pain is always there, or when I get it, it's really strong and it's really stabbing pain. So that's all really helpful in helping us decide how are we going to treat someone. I think your other question that you asked before that I'm not sure I fully answered is that even though I saw people twice a week, we did treatment for about 30 minutes. That's historically in the literature, the research literature, as being effective for pain treatments.
That's great. And that's very, very important so that people have that informed choice. So when you go, because, not everyone as a practitioner may know this. So you as a consumer can actually share it and share this podcast with your potential care providers as well. So you can advocate for your treatments and the way that would work, because, I've heard you speak so many times and we talk about how dosing matters. Can you speak to that, please?
Sure. Dosing is something that we talk about, like how frequently does someone really need to come into the office for treatment? And there's lots of factors that influence that. Like, again, talking about individuals, like what do they really need? But the research tells us that twice a week for treatment has been very effective for pain conditions. And we're also finding it can be very effective during certain phases of fertility treatment. We'll go into that later, but the other piece is that, one and done is not enough. And there's other pieces of approach. Let me say this in a different way. When we think about IVF, specifically in vitro fertilization, most of the research that we've seen is where, people just do acupuncture on the day of embryo transfer. And that's not a really typical way we would approach treatment for someone to address the whole person, to kind of address all of the things that they're dealing with and supporting their fertility at the same time. We would work with them for a bit longer. And it's kind of like thinking about, well, if someone has hypertension, which is a condition that's chronic, you have to manage it. It's not something you can just treat with one pill and be done with it. And your hypertension or high blood pressure is addressed for the rest of your life. So is it also true with acupuncture. You can't just expect one session, 30 minutes with needles in your body in very specific places to be enough to sort of like radically transform everything for everyone.
Absolutely. It's not that magic pill we'd like it to be. And sometimes is some magic, but it's truly about being consistent with the therapies and treatments that you are pursuing. So let's speak to the hormone piece, because we're talking about vulvodynia and painful sex. And as we age, tissues can just naturally become thinner or more tight. How do you speak to that? And does that come into play with the treatment strategy when it comes to like the different phases of your life? Like I can see that how, vulvodynia may be even more prevalent. Maybe you can speak to this too. Like, is it more prevalent the older we get?
I can't speak to age being specifically a predictor of whether or not someone will get vulvodynia. In fact, if we know that the pain is because of a hormone change, specifically like your estrogen levels are going down, and that changes the texture of the skin, the thickness of the skin, making it more easy to tear, making it more easy to get agitated with any kind of friction or pressure, that's a reason for why you're having the pain. And therefore, vulvodynia is no longer really the diagnosis. The diagnosis for vulvodynia really does have to be for no other clear reason. You can have vulvodynia alongside other different treatments. So you could be aging, also have an estrogen deficiency, but still there's some other thing that's telling us that no, this is actually not just because of estrogen changes or hormone changes with aging, that actually this is vulvodynia. But I do want to be careful because I'm not a diagnosing clinician in the United States or in Canada, and I don't diagnose vulvodynia. I rely on the referral from my the specialist that I work with here in Portland, Oregon, who tells me, like, I've done the assessment. They'll do a cotton swab test. They'll do some other assessments, and they'll be like, yes, definitely this is vulvodynia. Why don't you work with this patient? So I guess in summary to this, really your question is that vulvodynia is for diagnosis specifically in hormone changes. Let's come back to hormone changes. When we think about aging, we do need to, as acupuncturists, use our therapy to help bring blood flow to the genital tissues so that then it can be estrogenized or absorb topicals that are being applied, like topical estrogen or other pain creams, so they can do their job better.
That's great. Do you also combine it with a Chinese herbal medicine or other supplementation?
I do. As you can see behind me, there's some of my herbal library. I don't know, my dispensary. Yeah, I do combine it. It depends on the person, obviously. Like there's going to be certain people who don't want to take Chinese herbs, and that's absolutely fine. But then there's other folks who are really into it, and there's no reason why they can't try it. They've tried everything else, and they want to look at another way to see if they can help address their pain. And I have found in clinical practice, I don't have research for this, but in clinical practice, I have found physical therapy, Chinese herbs, and the topical pain creams have been really helpful for these patients.
Awesome. So, and with these patients, are you seeing them ongoing, or is it, just a certain set of sessions and then they're up and on their way?
I really set a very clear expectation that we should see at least 50% reduction in their pain within 12 weeks. And if we don't, then we should keep going and see if we can reduce it again, if we can get that reduction at 24 weeks. But what I really don't want to do is if someone's not doing well, that we look at other therapies to bring in, because they may need something else.
Right. Like you mentioned earlier, like pelvic floor or something like that, right? Yeah. I personally think that we should do multiple things at the same time. And as researcher, it's difficult because you want to just look at one parameter at a time just to see really what works. Right. But in real life experience, people just want it to go away, right? Like, I just want to have good sex, for Pete's sakes.
Yes. Enjoyable sex.
Enjoyable sex. Yeah. So then maybe even with that, like, touching upon or seeking out help for the mental emotional help, right?
Right. That's when we're talking about sexual confidence, where, you can, if it's always painful to be intimate, it's easy to expect pain with intimacy, and it's kind of hard to turn that off if you've had it for a really long time. So working with a mental health provider who really specializes in this area is super helpful to deal with pain counseling, to deal with we call this catastrophization, but really what it is I don't really like that term so much, but it's really about where the expectation that pain will happen makes us expect it, and we kind of tense up as a result of it. And we want to help ourselves be relaxed and receptive and enjoy the experience.
So do you have a couple of tips around that? How can we, or, if someone is going through this and there's this anticipatory pain, and then you want to actually avoid sex, but then what if you're also trying to conceive? So it's like you want to avoid sex, but you can't avoid sex because you want to conceive. So what do you tell someone like that? Like, what are like 3 little tidbits that you can provide to share?
That's a great question. I think I bring in more folks because I think it's important that we have very well trained providers, counselors, coaches who really understand the terminology, comfort levels, safety around intimacy. So I'm not going to be pushing someone to have sexual penetrative intercourse in the sense for procreation if it's so painful that it's causing more harm than good. And there's this push and pull, as you were just saying, for those of us who are trying to conceive and also have pain with intercourse, pain with any kind of penetrative sex or any touch whatsoever, where touch would typically be considered pleasurable instead becomes just untenable. You can't tolerate it at all. The folks that I like to bring, so Dr. Lori Brado, who's from the University of British Columbia, who is just a well-known psychologist and researcher in sexual, in all things sexual, basically. I tend to refer people to her website because I believe that she has resources on there for folk. I'm speaking specifically to the Canadians. I believe that she has resources on how to connect to providers who know what to do. In the here in Portland, I have a collective that I've just joined. It's the Rose City Sexual Health Collective. So I have a sex coach. I have a marriage and family therapist. I have a pelvic floor physical therapist that I will be working with to help support them. So really, I like to bring more folks in. But the really simple things that we add in is that give yourself room and time. Rushing is probably not your friend. The second thing is lubricant. We must use lubricant. Please don't expect comfortable sex without lubricant if you know that you already have some discomfort with sex.
What's your favorite lubricant on that note?
Oh, that's a great question. It's called, I was just looking up a bunch of them. It starts with a G. Oh my gosh. I'll get that for you. I can't remember the name of it right now, but I can see the bottle. Wasn't ready for that.
Oh, sorry. I know. Okay, just so you guys know, this is like a total last minute thing. I'm like, what did you talk about people's sex? Because like people actually have this problem and nobody talks about it. So we need to put it front and personal. And because we were initially going to speak to this research that you have done with regards to acupuncture and IVF outcome and whole systems Chinese medicine is what we talked about. And then also, acupuncture for decreasing anxiety while one goes through IVF and more, right? But anyway, this is like not even just a sidebar. This is like so important. I'm like, we just need to lead with this one.
100% it's important because it's the lead into making babies. And then, if we can't, we can do IVF, but if we can do all the steps before, that would be ideal, and to enjoy it, because it gets to this point where if you've been trying for a while, that probably can, make a big impact on relationship and the receptivity that, you were talking about. So I think we're going to be interviewing Alison Armstrong. I don't know if you've heard of Alison Armstrong, on the psychological kind of, effects of like intimacy and improving that receptivity. So I'm excited to have her on next week. And I think silicone is my favorite lubricant base. Was yours a silicone base that you were thinking of?
We don't want to use sticky water-based or any kind of thing with parabens, obviously, because that can irritate tissues. But the main ingredient that I tell everyone to look for in any product is propylene glycol, because propylene glycol can really irritate genital skin.
Right. So just like a plain silicone without any of like the glycerin or things like the sugary stuff that can feed yeast. And I love the whole integrative concept, because you can rule out infections and estrogen deficiency, like you were talking about with a physician. And then, which is really important, like having a village of care.